Hi everyone, we're going to go ahead and start our fluid and electrolytes, acid and bases PowerPoint lecture. So many of you have already finished your readings and you're probably figuring out that this is a pretty complicated system. However, my goal for you is I want you to learn the patterns of what's going on in the body. Why is it that we see fluids or electrolytes shifting in the bloodstream? So we're going to kind of do some practice questions, discuss a few things, and I think you'll find this a lot of fun. So first, you want to test yourself. So intracellular body fluid accounts for approximately 40% of total body. Does anybody know? Water. TBW stands for total body water, and an adult male has a TBW. Does anyone know what percent of their body weight? 60% of the body weight. Okay. Now the next question, what accounts for 2/3 of our total body water? So in other words, where is all the water at in our body? Is most of it going to be outside the cell or inside the cell? And I think you may be slightly surprised by the answer. So hopefully you said inside the cell. Intracellular fluid makes up 2/3 of our total body water. And if that's still a little confusing, think about every single organ, every single muscle, every single tissue, and what is it made up of? It's made up of cells with different functions. And so each of those cells requires water in order to survive, in order to thrive, in order to do its job. So if we were in class, I would test you, of course. I would ask you, okay, so inside the cell, obviously, we have water. But where is water located outside the cell? And you really have to think hard because it's not as obvious, right? Hopefully you're thinking about areas like the bloodstream, inside the vessels, okay? Inside your intestines, your entire GI tract has water. Sweat, urine, all the extra spaces, your lymph fluid, synovial fluid, okay? Pleural fluid, which you know resides in the respiratory tract as well. Okay, so make sure that you understand all these sources, that you know where fluid is important. So if there's a shift away from extracellular fluid, all of these components are going to be affected negatively. Another thing I want to mention is the difference between first spacing, second spacing, and third spacing. I mention this because you may talk to a nurse in the hospital and they say something to you like, oh, this patient is end of life and they have third spacing. And so you would say, oh, okay, but what does that mean? First spacing is discussing fluid that is found inside the cell or inside the vascular system when it's outside the cell. So those are pretty straightforward and expected. Second spacing is going to be edema. So at that point, we're talking about interstitial spaces. You guys remember what happens when you don't have enough protein and how fluid leaks out into the interstitial spaces and somebody looks really puffy and they blow up with fluid, right? That's second spacing. That's that edema. Third spacing is a different type of interstitial fluid. It also goes outside of the interstitial areas into other areas such as the pleural cavity, the peritoneal cavities. So it's not a normal accumulation of fluid. This fluid becomes trapped and it's unable to be used functionally. Whereas with second spacing edema, usually the lymph can pick up that fluid and return it back. Okay, so we do see third spacing at end of life. That's where you'll see fluid kind of go in strange places in the human body. Okay, true or false? Lymph and interstitial fluids are components of intracellular fluid. All right, and hopefully you said false. Pretty straightforward. True or false? Total body water decreases with age. What do you think about that one? True, right? But why? Why is that true? What happens to the human body as we age in terms of your lipid component versus protein or muscle? So as we age, we tend to lose muscle, we tend to gain fat. Fat does not like water. Therefore, the more fat that you have, the bigger risk you have of overall being depleted of the correct amounts of water throughout your body. So somebody who is extremely overweight with extra lipid and fats, they're actually at a higher risk for dehydration than somebody who is not. So certainly because we know this, we can try to combat this at an earlier age and make sure that we do extra work to maintain muscle in our bodies and everything that we can to make sure we don't add on extra lipids. Okay, true or false? Newborns are at increased risk for electrolyte and fluid imbalance due to their increased body fluid percentage. So very, very, very true. At birth, the total body water of an infant or a neonate, which is a newborn, it's 80% of their body weight. They have a super high metabolic rate and increased body surface area. Because of this, the slightest shift can throw their whole body out of whack. And their kidneys, their renal system, may not be able to counteract an electrolyte imbalance or fluid imbalance. Our kidneys do that all the time as adults. Newborns don't have that capability yet. And if I were to ask you, what do you think is the main reason that newborns would actually die from dehydration? What would be the cause? I wonder what you would think of. But across the world, especially third world countries where there's not as much medical help and or education, the main reason is diarrhea. So vomiting also, but diarrhea is number one. You lose so much water from your body with diarrhea. So here's just kind of a reiteration of what I just spoke about. I'd like to point out under aging, diminished thirst perception. This is really important to remember with your patients at the hospital. So you go in to see them and you notice they have water, next to their bed, but they're not drinking. And you're thinking, oh, they're not even taking care of themselves. I put this water there for them. But guess what? Their thirst perception is totally different from what it used to be at a younger age. They don't feel that desire to drink water, even though they may be extremely dehydrated. We drink water because we're thirsty. You sit in class and you decide, oh my gosh, I need to drink this water. I just feel like my mouth is dry. I feel dehydrated is something we say a lot. So they don't have that perception anymore. So you have to physically remind the elderly population to drink water for that reason. So there's a lot of pictures in your book. It's, fluid compartments are a little complicated. But what I really want to point out is the concept of osmolality, because I'm going to test you on this, and you're going to see this come up again. I want you to know what this crazy word means. So if you were to test yourself, what is osmolality? It's the number of solute particles per kilogram of water. So I'll say that again. the number of solute particles per kilogram of water. Okay? Notice I said solute. I didn't say sodium. I didn't say potassium. I didn't say glucose. Okay? It doesn't matter what the solute is. It's just describing how many particles of that solute there is per kilogram of water. Okay? So we're going to start to kind of look at that to determine if something is hypertonic versus hypotonic versus isotonic, and kind of figuring out where we are. Now, your next question naturally is, what is a normal osmolality? Okay, a normal osmolality in our blood is going to be 280 to 294 milliosmoles per kilogram of water. So that would be your units. Okay, and that's normal. So that's what we expect. That's kind of the correct amount of balance between solute and water. And if I asked you, what is the most common IV bag of fluid that we'll give somebody, what would you say? You would say NS, right? Normal saline. But there's more that you need to tell me, because bags of fluid, IV fluid, even normal saline, they come in different percentages, okay? And 0.9% NS is actually going to be our isotonic, it's called, fluid. That's going to be as close to the osmolality of our blood as possible. Therefore, if you are to give somebody a bag of that fluid, you're not really going to change the concept of the fluid and electrolytes in the blood. You're going to kind of just keep it the same osmolality. Therefore, things should not be shifting too much. You're just kind of replenishing what was lost by keeping the same osmolality. Okay? All right. Sorry for all the noises with the papers. The physician tells you that your patient is urinating more often in order to compensate for a disruption in her fluid electrolyte balance. You expect her to have a decreased serum osmolality. Okay, remember, it's the number of particles of solute per kilogram, and her body is urinating to compensate for a problem. Why would she be urinating so much? She's taking water out of the body. Why would that be compensating? That means that inside her blood, and that's what we mean by serum osmolality, in her blood vessels, there is too much water content and too little of the electrolytes or solutes or particles. And her body is compensating by pulling out the extra water, trying to make a better balance. Okay, so let's say that you're, your normal sodium levels are 135 to 145, right? So let's say all of a sudden you add so much extra water into your blood. Okay, let's say we took an IV and just added just straight water into your blood. And then we took a sample of your blood to see what the sodium level is. Do you think it's now going to be 135 to 145? Absolutely not, right? Your sodium level now is going to be dispersed and it's going to be very small. And so you're actually going to be hyponatremic, meaning below normal levels of sodium in your blood. And that's just because we diluted it with water. So that's why osmolality is so important. And your body will try to compensate for you. I like this picture a lot. It shows you very clearly all the different forces that either pull water into or push water into the vessels where your blood is, or the opposite, into the cells. You can see the lymph, you can see venules, you can see arterioles, okay? So what's important for you guys is to really know these and to know which ones do what. If you look at the bottom here, capillary oncotic pressure, you guys know this is my favorite pressure ever. I'm a little obsessed with it. And if I were to ask you what causes oncotic pressure, you would be able to tell me plasma proteins, right? And it's a pooling pressure, so it's going to pull water into our vascular system, into our blood vessels. And that's a very, very important concept, because look at where it would be if we didn't pull it in. Okay, it would be where? It would be in this interstitial space. Okay, and that's where we get that edema. Okay. So do remember to review those. Take a look at osmosis, look at osmotic pressure. Be sure to be very comfortable with these. Okay, and this is kind of what we were just talking about, but being aware there's water pooling pressures and there's water pushing pressures. Okay, so as a reminder, we talked about first spacing, second spacing, third spacing. Which one was this type of edema, where there's an accumulation of fluid within the interstitial spaces? This is going to be second spacing. And what type of edema would you call this if you were looking at this? Definitely some sort of pitting edema. You can see the puffiness of the foot, the outline here. And you can see actually fingerprints here as well that are indented and not bouncing back. Okay, that's way too much fluid in that area. All right, now we kind of start to talk about our patterns. This is where it gets really neat. So sodium chloride. Okay, you guys know sodium chloride as table salt, right? Table salt, salt. Okay, but why is it that sodium and chloride stick together? Take a look at the electrons. Take a look at what's happening. Okay, the chloride needs one more electron, and the sodium needs to join someone else. It only has one, right? To be stable and have electroneutrality, which is what these electrolytes want to do. So sodium and chloride naturally tend to come together. Therefore, how does this affect you when you're looking at your patient and you're looking at their sodium and chloride levels? When you're trying to figure out your care plans and you don't understand why the chloride is high, why is the sodium high? The pattern I want you to know is that sodium and chloride, because they come together and they're attracted, when one goes up, the other one tends to go up. When one goes down, the other one tends to go down, proportionally to each other. So look for these patterns in your patients when you look at their labs next time. The other thing I want to mention is what follows sodium. What follows sodium in the body? And it's water. And I bet most of you said water. Now, for that reason, you could see extra fluid in someone's body, okay, just from the simple fact that they overloaded their diet in sodium. Okay, it can make their blood pressure go up just because there's more fluid in the vasculature, in the arteries, causing a higher blood pressure. So also be aware of the pattern of water following sodium. Where sodium goes, water goes. Okay, this is your absolute favorite raw system. Hopefully you know what raw stands for at this point. If you don't, please go back and review. There's some good YouTube videos as well. Renin, angiotensin, aldosterone system. Now, this is probably the arch nemesis of nursing school, nursing students, right? The system, because you kind of just have to memorize it. But there's something I want to point out specific to us today is look at this part here. Sodium and water retention, increased blood pressure, okay? So at this point, if something goes wrong with this system, okay, then maybe you're not going to have this problem where you have sodium and water being kept in the body. If this system is triggered prematurely or erroneously, you're going to have this problem, which could potentially throw your electrolytes off and also increase your blood pressure for not good reason. So again, you just need to know that the raw system is involved in electrolyte balance and in water, and how much water that your body has. Now, this system happens all of the time. It's constantly being triggered for you. It gets triggered by low blood pressure, obviously, because the end result is what? Increased blood pressure. So it's going to be triggered when your blood pressure gets too low, this whole cascade of events. And your end result will be a higher BP. Okay. Next, I want to talk to you about ADH, which is Antidiuretic Hormone secretion. This is really important because we're going to talk about diseases that are involved with irregular amounts of ADH secretion. So if it's an antidiuretic hormone, what do you think is happening in the body when this is released? So you might have to work backwards here. A diuretic does what? A diuretic is going to cause you to create urine, lose water, and pee, right? An antidiuretic hormone is going to cause your body to hold on to water, to keep water into the body. We have a couple different diseases. For example, SIADH is syndrome of inappropriate ADH secretion. So that's way too much antidiuretic hormone. And you can imagine that that could cause electrolyte imbalances in our bloodstream. The opposite is diabetes insipidus, which is where there's too little ADH and the body just starts peeing out all of the water. Okay, so that's kind of just something to throw out there to kind of make everything start to make sense. Now, we already mentioned NS, right? Our 0.9% sodium chloride. So this is an isotonic solution. I'm sure a lot of you have lots of questions. You want to know what are other isotonic solutions, and I'm not going to give you all of them, but I will give you a couple big ones. Lactated ringers is another one. I can't list you all the ingredients in LR because there's so many, but if you look it up, you can see the exact percentages of each thing involved in LR. It's named after a physician that discovered the meaning behind it. So you see lactated ringers or LR mainly in surgeries in the OR. Okay, you're not going to see it as much on the hospital floor unless someone usually is coming back from OR and they still have it running. Okay, then we usually switch them over to NS. D5W is another isotonic solution. D5W is 5% dextrose in water. Okay, so what are reasons that we would go ahead and give an isotonic solution like this one? Why would we give it? Think about it and think about what your answer would be. The more common reasons we would give an isotonic solution would be hemorrhaging. Okay, so someone is losing blood, just straight blood that is already balanced, right? And we're just replacing it. Excess sweating can actually be a reason. Severe wound drainage, or someone's inadequate fluid intake. Okay, those are the primary reasons. And again, is this going to have much of an effect on causing a cell to shrink or swell? No, our goal is just to rehydrate across the board. So no big changes there. I would say generally, this is generally going to be one of the safest solutions to give a patient, although it is still considered a medication, and potentially you could still harm someone by giving it to them erroneously. Okay, a hypertonic solution. So I'm going to talk about two things. This slide is talking about hypertonic alterations. So this is where we're talking about in the bloodstream, there's too much of a solution of some kind, okay? We also can give hypertonic IV solutions as well. So I will talk about that as well. So let's start talking about hypertonic alterations. So when you see that word, hyper, you know there's too much. There's an abnormally high level of something. Hypernatremia is going to be an abnormally high level of sodium in the bloodstream, okay? When you see natremia, you know that we're talking about the bloodstream. We're not talking about the urine. We're not talking about the lymph, okay? You're immediately thinking, what is happening in that bloodstream? What is traveling through the blood? Too much sodium. Greater than 147 milliequivalents, okay? Regarding that, what do you think can happen based on a pattern that I taught you about earlier? If you have too high sodium levels, what other electrolyte could be thrown off balance at this point? Hopefully you remembered chloride. So you could also get high levels of chloride in conjunction with this sodium. Okay, remember I told you they float together. They tend to work in the same pattern. Okay, now there's different reasons that this could happen. I would say generally it's not super common that we're going to see hypernatremia in a patient. It's possible. It's more common that you would see a low sodium. Now the next thing I want to talk about is a hypernatremic or a hypertonic solution. I'm sorry. Before I go, I want to give you some reasons that you would see hypernatremia. I apologize. Some reasons you could give it, you could see it. Perhaps you erroneously gave them a hypertonic saline solution. Okay, that's an example we never want to think about, but if a nurse or a physician orders the wrong type of solution and we give it to them in their bloodstream, we could cause hypernatremia, okay? It's possible. Oversecretion of aldosterone. So remember we talked about the Roth system. If the body produced too much aldosterone, we also could get sodium retention, right? And therefore water retention. But that sodium retention could be enough to cause a hypernatremic state. It's very rarely dietary. It's more or less we see this we do see this a lot in infants though. Okay. Alrighty, so I was talking about hypertonic solutions. So an IV solution that would be hypertonic, okay, could be instead of 0.9% NS, you're thinking more like a 3 to 5% NS solution. So that would be an example of a hypertonic, okay. Now my next question for you is, why in the world would we give someone a hypertonic solution? Right? Doesn't that seem kind of crazy to put all this extra solute into the bloodstream? So why do you think we would actually do that for somebody? Hopefully you're thinking, well, perhaps if the bloodstream was deficient, right? If your bloodstream was deficient of enough solutes, enough electrolytes, we would try to balance it by putting in a hypertonic solution. Okay, and if you thought that, you're correct. Now, let's take this a step further. If you were to erroneously give someone a hypertonic solution, let's say you give someone erroneously a 5% sodium chloride solution and they didn't need it, what is the effect on the cells? Not in the bloodstream, but the cells outside of the bloodstream. How will they be affected by you giving this patient this hypertonic solution? Are the cells going to shrink? Are they going to get bigger? Are they going to stay the same? If you now have too much sodium chloride in the bloodstream. Okay? Hopefully you recognize the fluid shift. So if you put too much, or if you have too much of this hypertonic solution into our bloodstream, it will pull water away from the cells and actually cause the cells to shrink and become dehydrated. So it can be dangerous, very dangerous. Okay. Going further, another reason that you could have too much of an electrolyte in your bloodstream could just purely be water deficit in the bloodstream. That's it. Just pure water deficit. Okay. Which could lead to what's called intracellular fluid dehydration. Okay. So this can happen if your kidneys are damaged and they're just releasing too much water and not holding on to it. That's one reason. It's usually related to some sort of kidney damage. Diabetes insipidus, we talked about, is another reason. Remember that is not enough ADH hormone. Okay, that can also cause this type of alteration. Hyperchloremia. I don't want you to spend too much time on this. I just kind of want you to be aware of the fact that this is a possibility. Okay, we're not going to spend as much time on that one. And you can see it actually occurs with hypernatremia. And remember, there's that pattern. Okay, this is a great visual in showing, what happens to the cells. So we just talked about hypertonic solutions. They're going to cause the cells to shrink, right? Because it's going to pull the water into the bloodstream to follow the sodium. On the opposite spectrum, what about if we erroneously gave a hypotonic solution to a patient? Let's suppose that you gave, instead of 0.9% NS, you gave 0.45% NS. Okay, that is a hypotonic solution, right? That's less than the normal osmolality that we're expected to have in our bodies. What can that do to the surrounding cells if you now have this off-balance amount? There's too much water. Okay, the water will actually leave the bloodstream and go into the cells and will cause the cells to swell and even burst. Okay, and that can be a very dangerous situation if it was done for the wrong reasons, okay, or erroneously. Now, in the same way, if you had too much water and not enough electrolytes in your blood, you would have decreased osmolality. The most common form, or one of the more common forms that you're going to see, is hyponatremia. And I'm actually going to talk about that in the next slide. Free water excess means too much excess water, okay? Also can cause the exact same effect, right? So you know the normal sodium levels. Hyponatremia is one of those ones you need to know. You need to know hyponatremia. You need to know hypernatremia. You need to know hypokalemia, okay, that's potassium, and hyperkalemia. Finally, you need to know the calcium content. You need to know the differences with hyper and hypocalcium, okay? The rest of them, important, but not as important, okay? We're talking about things that are going to affect the heart, that could potentially kill someone, that could potentially cause a dysrhythmia. So hyponatremia, like I said, is a little bit more common. I want to tell you about my friend. This is one of my best friends, actually. He was hiking in the Grand Canyon at this time. And what he did, and he's in very good shape, he planned ahead. He knew it was the summer. He was going to hike down miles and miles down this deep canyon, okay, in the sun. And he left later than he was expected to. And he prepared by bringing tons of water. So he brought water, he had it on his back, he constantly was drinking water, okay? So he gets down to the bottom, all right? Now, granted, he's been sweating profusely at this point. He's hot, they're tired, they get down to the bottom, and they realize, okay, well, can't really stay here long. We gotta go right back up. That's kind of the problem with this hike. So he's like, well, I have all my water, I'm good. He starts heading back up. Still sweating profusely, still super hot, working really hard, right? His body's working, using up things, okay? Using up electrolytes because of the exercise. He gets about a third to a half of the way up the mountain, and he starts to feel nauseous. He starts to feel dizzy. He starts to feel sick. He starts to want to vomit, okay? And then you're thinking, he's like, well, I don't understand. Like, I must need more water. So what does he do? He drinks more water, okay? Just has it on his back, just starts chugging water. He's like, I don't get it. I'm drinking water. He starts to feel more sick. Starts to get really tired. Starts to get a little out of it. Luckily, his girlfriend at the time was able to find help, but she also was starting to feel some of the same effects. And the difference was she ate something before she got really bad. So what happened here? What happened to this guy? What went wrong with their plan? And as you probably figured out, he was not drinking electrolyte water. He was drinking plain water. And what happens when you're sweating profusely and you're exercising? You're using up all of this sodium. The sodium is just coming out. And he had a severe and acute case of hyponatremia, which can result in lethargy, confusion, decreased reflexes, seizures. Okay, worst case, coma and death. He very well could have died on that mountain. And so, as you can imagine, as being my best friend, I had quite a few things to educate him on after this happened. And as soon as he started to tell me the story, I knew exactly what was going on. What he should have been doing was drinking electrolyte water and eating snacks. So if anyone decides to go do this hike, please remember electrolyte water. Now, on that note, random question for you. At what point do we tell our patients that they should be drinking electrolyte water in terms of exercise? So, I mean, a lot of times we see patients, and we are guilty of this ourselves. We like walk for 20 minutes and we're like, "Whoa, man, I need to drink a Gatorade," right? But actually the recommendation is 60 minutes of cardiovascular workout. Now that means you could be doing Zumba for an hour, sweating. You could be running for an hour. You could be doing an increased difficult sweating hike. Okay, it kind of depends, but when you're doing it for that long, at that point you do need to replace electrolytes. Less than that, a half-hour jog here or there, water should be sufficient. Now, if in doubt, of course, you're going to do electrolytes, right? The other thing to mention is Gatorade is very, very high in sugar, and so patients will actually gain weight and become mildly obese just from increased Gatorade consumption. Reasons that you would see this other than my friend and Grand Canyon hikes, you could see this from very severe burns, okay? A hyponatremic state. Very severe burns result in electrolyte loss. And you could see this with vomiting and diarrhea. You could also see it from water excess, such as in this case as well, and not enough sodium intake. So it's kind of fascinating. So certainly, I'm so grateful that he was okay. Now, water excess. So we've talked about this a few times, but what in the world would cause this? There's actually a psychological condition or disorder. It's called compulsive water drinking. Now, you may be thinking to yourself, oh, I think I may have this problem. Okay, but this is, this is a serious. This is like an obsessive compulsive disorder, but with water drinking. So this is somebody who needs to constantly be putting water and ingesting it. You cannot take the water away from them. You can't stop them from doing it. It's all about maintaining this water drinking. So that is actually a real condition to be aware of that's out there. That certainly can cause hyponatremia. SIADH down here, we talked about that. So way too much antidiuretic hormone can cause your body to hold on to water, including in your vessels, and will dilute your blood. Okay, can also cause hyponatremia. Decreased urine formation. If there's an issue with your kidneys, again, this is something that can happen. Now, some of you may remember there was a radio show that, I don't know if any of you have heard of this, probably. There was a radio show where they did a contest, and it had to do with drinking a certain amount of water. And someone actually died from water excess. Like, died as a result of participating in this contest because they diluted their blood so fast, the electrolytes were thrown off, and the patient died. Or, excuse me, the person died. So, a lot of bad things can happen, but weakness, nausea, muscle twitching can be an early sign. Headaches, okay, weight gain would be the water being withheld in the body. You can cause weight gain, certainly. Confusion and convulsions can happen secondary to cerebral edema. Okay, so sometimes if the capillaries or the blood vessels are overwhelmed with water, water starts to leak out of the membranes. And you will hear about this and read about this more as you learn more about more complicated diseases. But we're always thinking about the brain. Cerebral edema is incredibly dangerous. It is a high risk for death, damage, brain damage. And so whenever you put way too much fluid in your vasculature, you're at risk for the fluid leaking out in the brain, and there's no extra space in the brain or in the cranium to allow for that extra fluid. So you have a problem there. Hypochloremia. The main causes of this electrolyte imbalance is going to be, if you can imagine, what other electrolyte could be deficient to cause hypochloremia? Okay, hopefully you said sodium. Remember, sodium chloride. So it could be the result of hyponatremia. Okay, certainly acid base can be off. Vomiting, excessive vomiting, you actually lose a lot of this electrolyte. Another reason you could see this is if you excessively use diuretics. They can find this type of acid-base imbalance. Not as common, but I do want you to realize and associate it definitely with vomiting. Okay, this is a little review for you. Everyone should get this right. Potassium is the major intracellular cation, right? Okay, here is something you probably did not know about potassium, which is fascinating. Insulin has a very big effect on potassium in our cells. Does anybody know what it is? Because the other ones kind of make sense, right? The other ones on this. Okay. Insulin actually facilitates the shift of potassium into the cells. So pulling potassium out of the blood into the cells. Now, knowing that, do you think it's possible that sometimes insulin is used to treat hyperkalemia, high potassium levels? Do you think insulin is used for that at times? And it absolutely is. We normally think of insulin as strictly related to diabetes and pulling sugar into the cells and whatnot, but it also facilitates potassium into the cell. Potassium is required for glucose and glycogen deposition into the liver. Okay, so using glucose and depositing it into the liver. It also helps to get electrical neutrality in the cells. Okay, so potassium is a biggie. Sodium and potassium are two big guns. You have to know those. You have to know everything about them. You have to know what's going to cause them to go up or down. You have to know what are going to be your patient's symptoms if you have too high or too low levels of these in your blood. Okay. And if I were to ask you, what organ do you think is going to show effects of potassium imbalance first? What organ would you say first? And hopefully you are thinking of the heart. Okay? The heart uses electricity. Potassium, sodium, chloride, everything, these are electrolytes because they're involved in electrical activity. A normal cardiac rhythm is maintained with electrical neutrality, okay? So when you have these imbalances, what could you see in the heart? You could see a dysrhythmia. You could see, worst case, you could see heart failure. You could see, the inefficient attempt to cause the heart muscle to work and not enough electrolytes to make it happen. And blood can't be pumped at all. The heart could stop. You could go into a deadly dysrhythmia that is not efficient. There are all these very, very bad things that can happen. So we're going to talk a little bit about these. So hypokalemia. So you know the normal range, so you can easily figure out what would be hypokalemia. You can also take a look at this picture. Sorry, it's cut off a little bit. It should be in your book as well. And effects on the EKG. And I do want you to recognize some of these changes that you can see. Now, what do you think would be a reason that we would have too low potassium levels, let's say in your patient? Now, some of you are probably saying, oh, they're not eating enough potassium, right? They're not eating enough bananas or whatever it may be. But actually, we rarely see this happen due to dietary reasons. We can see it in the elderly, certainly from dietary reasons sometimes. But one of the major reasons would be alcoholism, okay? If someone is drinking a lot of alcohol all the time, they tend to replace food and calories with alcohol. So that's one reason we could see it dietary. Anorexia is a cause of hypokalemia. The other major reasons, if you were to think about it, are either kidney disease. Okay, so remember again, kidneys are very much involved in our electrolyte balances. Kidney diseases, GI diseases, excessive diarrhea is a reason. You can lose a lot of potassium from diarrhea. You can get kind of pulled out of the body that way. Laxative abuse. This is one to be aware of, especially as you're working in the community, that especially teenagers and also, really middle-aged adults, we're finding laxative abuse. And the reason is weight loss. They don't want to gain weight. As shocking as that may seem, it actually works. It's terrible for your body in many ways, but it causes your body not to hold on to or reabsorb hardly anything that you've eaten. And so it comes right back out and you don't gain the electrolytes that you should be gaining from your food and your drinks. So therefore, you can see weakness, certainly. You can see neuromuscular changes. You can see cardiac dysrhythmias. okay, problems with repolarization, and etc. Okay, so that was hypokalemia. Now we're talking about hyperkalemia. So does anyone know the reason, some of the major reasons that we see hyperkalemia? So why would our patients have way too much potassium in their bloodstream? So sometimes if there's a lot of trauma, a lot of cellular trauma, for example, massive burns, maybe a massive crushing injury where cells in large amounts have been destroyed. Think about what's primarily inside your cells, right? It's potassium. So if you destroy a whole section of the body, just crush it, all of the potassium leaks out of those cells and then gets reabsorbed and pulled back into the bloodstream just because that's what your body does. Okay, that's exactly how your body works. It picks up the pieces and it tries to fix it. Okay, those are two major reasons. So when you have a big motor vehicle injury or massive burns and things, we're always looking for these imbalances. We kind of expect it. Kidney problems, of course, okay? If the kidneys are not excreting enough of your potassium, then we're going to have the same problem. And there are drugs that also affect that as well. What about insulin? How could your insulin levels affect or cause hyperkalemia? Based on what I've told you, would it be too much insulin or too little insulin? Hopefully you said insulin deficiency. Okay, remember that we said that insulin shifts potassium into the cells out of the blood. Okay, so if you have insulin deficiency, it is possible that you could secondarily have hyperkalemia. Finally, one more that would be a surprise to you are salt substitutes. Salt substitutes patients will use because they think that they are helping themselves. They're like, oh, I'm not supposed to have a lot of salt. I'm going to use a salt substitute and be a good patient, do a good job, and take care of myself. If you look at salt substitutes, they're mostly potassium. And a patient can actually dangerously throw themselves, into hyperkalemia from salt substitutes. So please always kind of find out how your patients are cooking and what they're using. And if they tell you they're watching their sodium, say, are you using a salt substitute? And if so, can I see it? Or can you take a picture of it for me? Okay, this is a biggie. You need to know these symptoms, these manifestations. Okay, early mild attacks versus severe attacks. Okay, notice a severe attack can result in cardiac arrest, of course. Okay, early signs would be cramping, tingling, okay, restlessness, like something is just wrong. It's that whole neuromuscular effect. When you're thinking about the heart is not going to be able to conduct appropriately. You could have rapid depolarization, as in, very, very fast. Narrow, taller T waves. And here's a little picture for you with normokalemia, hypo, and hyper. So yes, you need to know these. You might have to spend a little bit of time to kind of piece them together. Okay, you will see these again in your critical care class. You'll see these again when you're talking to someone about EKGs. Okay, so these are very important. So I'm not going to spend too much time on that. Okay. Calcium and phosphate. So this is another pattern, another relationship that I want you to know. So how are these guys related to each other? How do they affect each other? So the key is that they're inversely proportional. So again, they are inversely proportional. So if you have high calcium levels, what do you think you're going to see in your phosphate levels? They're going to be low, and vice versa. Okay, one can cause the other one to shift. So again, next time you look at your electrolytes on your patient and you see calcium is off, look again at phosphate and see, are they inversely proportional? And most likely they will be. It's kind of fascinating. Now, the serum concentration level that you see at the bottom of this page, 2.5 to 4.5, that's actually phosphate. Serum calcium levels can range. One range you may see is 8.8 to 10.5 excuse me, milligrams per deciliter. Okay, so this is just a pattern for you to know. With calcium, it's important, but we're not going to talk a lot about calcium today, mainly because you will review this again when you start to talk about osteoporosis and other things. But I guess what I would like to point out now, while you're starting to make all these connections, is that in order to absorb calcium, what do you need? In order to build strong bones, okay, which we need, right, as human beings, because we're constantly moving. This is how we stay strong. This is how we prevent patients from getting fractures and, breaking their hip and breaking this and breaking that and osteoporosis and scoliosis, okay? What do we need other than calcium? We need vitamin D. You need vitamin D in order to absorb calcium into your bones appropriately. You could have all the calcium in the world and you don't have vitamin D and you're going to be in trouble. I tell you that because that's something you have to start educating your patients on now, not something that you can wait on. Now, with the relationship that I taught you with calcium and phosphate, back in the day, there was something called cherry phosphate. It was a cherry cola kind of thing, and it had very, very high amounts of phosphate. So what do you think was the problem for people who were drinking that constantly? Because we still have phosphate in certain cola products. The problem was the calcium levels couldn't be high, okay? The body shifted with all the phosphate, and patients were not getting enough calcium. Hypocalcemia, they're very similar things that you can see. Neuromuscular excitability, convulsions, tetany, you can kind of look that up too. Cardiac arrest, okay? So all of these guys, sodium, potassium, calcium, they all can cause cardiac dysrhythmias or cardiac arrest, okay? Too high, too low. We have this thin window of normal that we are obsessed with for our patients, and this is why. Can we replace calcium for our patients in the hospital? A lot of times we can. Can we replace sodium? Yes, right? We'll give them sodium in their IV. We can give them potassium, right? We give them those big banana pills, the potassium pills. Okay? The point is, we have to know what their levels are, and if we are the first ones to see on a lab that came back that they, let's say, their sodium is 100, okay? You better believe it, you gotta call that physician fast, okay? Because you may see it before the physician does, and you need to act on that. That's very dangerous. What if you see in the morning, you get in, and your patient's potassium level is 6.5 or 7, okay? Same thing. You need to call the physician and immediately escalate that information. The chances are they would probably move your patient to a telemetry unit where they could be followed for their heart. So just things, things to think about. Why did I put this slide on here? Because most of you are surviving off high caffeine levels right now. Probably right at this moment, you have a caffeinated beverage, as do I. So the main thing is you're going to see fluctuations, but the National Osteoporosis Foundation found that 330 milligrams of caffeine, or about 4 cups of coffee every day, increases the risk of broken bones. Now, granted, you have to talk about how big your cup of coffee is, okay, and figure out how strong your coffee is in order to figure out where you fall in that 330 milligrams of caffeine. Would I assume that 4 cups is bad and 3 cups is good? No, absolutely not. Do realize that caffeine does have an effect, generally, specifically coffee also, on your absorption of other nutrients. Okay, so that's kind of more FYI. Hypercalcemia. The only thing I would like to mention in terms of a relationship here is I want you to connect the parathyroid with calcium levels in the blood. Okay, and the reason I tell you this now is because we are going to be talking about the endocrine system in detail, and the parathyroid gland is a part of your endocrine system, and you're going to need to make this connection. So this is like your preview. Okay, the parathyroid gland rests, there's a few of them, on your thyroid. They're right there on top, and they give out something called the parathyroid hormone. Okay, and that is going to affect the calcium levels in your blood. Okay, so excess can cause very high levels, excuse me, in your blood. Okay, so we're going to come back to that a little bit more in the future. But just be aware, parathyroid hormone, and effects on calcium in the blood. Okay, here's that cherry phosphate I talked to you about. That's all we're really going to talk about there. Hypophosphatemia, we really see it a lot in alcohol abuse, long-term alcohol abuse. So if you're interested in working with this population, as some of you may be, and kind of going more of that route, do be aware that we have a lot of alcohol abuse patients that come into the hospital for other reasons. And this pattern of low phosphate in the blood is something that you want to have logged away. Okay, we are not going to go over these in detail. I don't need you to look at magnesium at this time in detail, but I do want you to be aware of it, as it is also an important cation. Okay, they're all important, just some are a little bit more important right now. Okay, and you can see alcohol is there again. So you're kind of seeing these themes, okay, of malabsorption, alcoholism, kidney problems, that kind of thing. And I'm going to skip through these. Okay, acid-base balance. So what causes acidosis versus alkalosis? Okay, it's all about changes in how we excrete acid from our blood, or perhaps how much we're making in our bodies. Why aren't we thrown into acidosis or alkalosis all the time? Because don't we have days where we're just terrible to our bodies and we drink, terrible things all day? Why don't we constantly have these massive shifts? And the reason why is we have buffering systems. We have these fantastic buffering systems. And we're talking about changes in hydrogen atoms, okay? A lot of times, diseases so previous diseases, will cause acid-base alterations in our bodies. And the acid-base alteration itself can be more harmful than the original disease that caused it. So that's to give you an idea of how serious this can be if it's thrown off. Okay, this helps explain the pH, because obviously the pH level of our blood is going to give us an idea of whether we're in acidosis or alkalosis. Okay, and again, has to do with your hydrogen ions. So a lower pH number is going to actually be acidic. A higher pH number is going to be more alkalotic, okay, or alkaline. Now, what are two ways that we can eliminate our acids? Because if you know these, it's very easy to figure out what can go wrong. Is CO2 an acid, an acidic component in our body? Yes, right? CO2 gas. How do we eliminate CO2? So hopefully you're saying we're breathing it out, right? So that is a volatile form. That is what we mean by volatile. Okay, we actually breathe it out. Okay, we can breathe it out. We can compensate for having too much acid by breathing out faster and getting rid of more CO2. On the flip side, we have non-volatile means. So how else do we eradicate acids from our body? And the main way is through our kidneys. We will actually pee out acid. Okay, so we have respiratory acidosis and alkalosis, which is going to have more to do with the breathing mechanism going wrong. And then we have metabolic acidosis and alkalosis. And that's going to have more to do with the ability to eliminate via the renal system and urine. Okay. As I mentioned earlier, we have buffering systems. Buffering systems are the reason that we do not get thrown into acidosis or alkalosis. It takes many things to go wrong and significant disease for us to actually experience acidosis or alkalosis. Okay, the normal pH of our blood, does anybody remember what it is? 7.35 to 7.45. That is a normal level. Okay, less than 7.35, we're talking about acidosis. Greater than 7.45, we're thinking about alkalosis. Okay. In terms of the buffering system, this is what I want you to know. I want you to spend your time on the carbonic acid bicarbonate pair. I want you to understand this and kind of understand how it works. Okay. Understand what buffering systems are and why we need them. Okay, and you can kind of read through these a little bit, but I think your book does a great job of explaining them as well. It's a fantastic pair. Okay, the other buffering systems, important to review, but I still want you to focus on the previous one. Okay, I do want you to know these definitions, and you already know how to do an ABG analysis, so that is going to still be expected. Okay, little video to help you. Please watch that and use any other videos that you would like. There's a lot of good ones out there. You have to figure out your own way of learning these, but you do need to know respiratory acidosis versus alkalosis. Same thing with metabolic acidosis versus alkalosis. And in your mind, you need to be able to decide which one is going to happen for what reason. Okay? It's all about figuring out what's happening in your patient's body. That's the one way that you're going to be able to make sure that they are safe. And that brings us to the end of this wonderful fluid and electrolyte topic. I hope that you enjoyed it. I hope that you enjoyed learning about the patterns. And now I really urge you to go back and apply these patterns to your patients, because when you start to see it live and see, oh my goodness, there is a pattern here. Oh, this makes sense. Why this one's high and this one's low. That's when you're going to remember. So thank you again, and I will see you soon for our next lecture. Take care. Bye-bye.